Hello, this is Taylor Losowski, and I will be presenting Confusion Assessment Method for the ICU, also known as the CAM-ICU. CAM-ICU is an evidence-based screening tool that allows healthcare providers without psychiatric training to recognize and identify delirium accurately and quickly in the clinical setting. The target population and demographics would be patients aged 18 to 99 in intensive care settings that have no previous history of cognitive disorder, including autism spectrum disorder, dementia, or Alzheimer's disease. The importance is preventing delirium and diagnosing delirium early can decrease ICU and overall hospital days and also improve health outcomes after effective interventions are implemented. Over here to the right is an example of a CAM-ICU flow sheet. It assesses different things such as changes in mental status by having GCS changes, assessing inattention by using the word Savahar or Casablanca, assessing for any errors when you say the letter A. You're assessing altered level of consciousness by using the Ross, the Richmond Agitation Sedation Scale, anything other than 0, which is calm and cooperative, and the Ross ranges from very sedated or unarousable to dangerously agitated, and then also assessing disorganized thinking by asking a patient these different questions and getting answers, and then just following the flow sheet for answers no or yes, or depending on the amount of errors, and getting a CAM negative or CAM positive result. So delirium and the CAM-ICU. Delirium is simply reduced awareness and confused thinking related to a disruption in mental capabilities that certainly affects quality of life by cognitive impairment, behavioral changes, and emotional disturbance. Anybody that's seen a patient with ICU delirium, it can range from hyperactive, where the patient is extremely agitated, they're pulling out their lungs in their tubes, they're having just many fluctuations in their mental status, or it can be hypoactive where the patient is withdrawn, they have a flat affect. There's just a very big change from when they initially came in to the ICU. So treatment for delirium would have proper sleep habits, remaining well-oriented, decreasing loud noises and poor lighting, and medication management, which anybody that works in an ICU knows that these are common things. If you're working in a busy ICU, it's loud, the lighting's not natural, and it can be very difficult for patients to sleep. Complications related to delirium are increased hospital stay, mechanical ventilation days, and healthcare costs, and then mortality and morbidity for patients. So the CAM-ICU is a simple format as seen on the previous slide. It can also be incorporated in your electronic medical record as it is at my institution. The flow sheet's already easy enough to use, but we also can just do very simple clicking and it just changes just right to the next topic. It can be done in seconds to minutes. It yields very important information ranging from CAM negative, the patient's not having signs and symptoms of delirium, to CAM positive, where you need to have some necessary treatment interventions in place. And it's very cost effective. Once you have this CAM-ICU printed and maybe laminated and hung up in all of your patients' rooms, or it's already incorporated in your electronic medical record, it's not something that's continuing to cost many healthcare dollars to use, but the incidence of delirium can be costly if there aren't effective interventions in place and there's not a proper diagnosing tool to use, such as the CAM-ICU. So moving on to literature review, I found 5 different articles starting with Vegabathan et al. Evaluating delirium and its effects on ICU patients. So again, there's 3 subtypes ranging from hyperactive, hypoactive, and mixed, which would be a mix between the two. Here in this study, 42% of patients were positive for ICU delirium, and they did use the CAM-ICU and the Ross. Some risk factors they found were smoking, diabetes, hypertension, and some hearing and visual impairments. And some factors that affected delirium rates were the use of vasopressors, catheters, and respiratory distress, which are all common in ICUs. Some environmental conditions were having no visible clocks, having restraints in the absence of daylight exposure, and some overall important findings were the need to recognize risk factors and modify those able, which you could ensure that you're having clocks in the room so a patient can see what time of day it is, trying to decrease your use of restraints, and opening up the blinds in the morning, closing them at night, making sure we're telling our patients, it's now 8 a.m., and then when night shift comes on, letting them know what time of day it is as well. And then also mechanical ventilation days and ICU stay days can decrease with early recognition of delirium. Giuseppe et al. Evaluated if there are any modifiable risk factors that can prevent delirium in ICU patients. Here they only used patients 18 years and older that were in a trauma ICU with no cognitive disorder. The CAM-ICU again was used to evaluate delirium, in which 38.7% were positive for delirium during their ICU admission. Some non-modifiable risk factors associated with delirium were sepsis, active infection, and comorbidities. And some modifiable risk factors were decreased opioid use, trying to use other therapeutic options such as heat, cold, or music therapy, ensuring there's a radio and television in the room, increasing mobilization hours by having physical therapy see patients so patients aren't bedbound for hours to days or even weeks at a time, and decreasing room transfers, trying to cut down on transferring patients out at midnight, at 3 a.m., so that way they can get a good night rest. In another study by Galinas et al., they performed a systematic review evaluating delirium assessment tools. They found that delirium is common in adult ICU patients and it unfortunately leads to mortality, increased length of stay, and prolonged mechanical ventilation days. 36 studies were used evaluating 5 delirium tools, analyzing reliability, feasibility, and validity. So the findings were that the CAM-ICU, along with the ICD-SC, were deemed very good because they were very reliable, feasible, and valid. In another study by Kosk-Dierligo et al., they evaluated delirium risk factors among 109 patients with no history of cognitive impairment. 18.3% of patients were diagnosed with ICU delirium in this study, and they found that patients with longer ICU stay and comorbidities had increased risk of delirium. Researchers deemed the CAM-ICU valid with specificity of 98.9% and sensitivity of 80%. Some conclusions and recommendations were that CAM-ICU is useful for professionals without psychological training, which is the reason I like to use the CAM-ICUs because I do not have any psychological training and I am able to use this very effectively and efficiently. And early identification of the risk factors can reduce delirium. Lastly was a review and evaluation of the CAM-ICU by Leonard and Rahman. They performed a comprehensive literature review evaluating the CAM. They used 33 studies from Google Scholar, CINAHL, and PubMed. They identified factors contributing to delirium, which were sepsis, sleep interruption, medication effects, and hypoxemia. And they also found that patients had increased ventilator days. Patients were being sent to long-term care facilities, and healthcare costs were increasing with ICU delirium. And 10% mortality increase each day delirium was present. The CAM-ICU sensitivity was deemed 81%, and the specificity was 98%, and it was overall deemed an effective assessment tool for the bedside. Some barriers reported were a lack of teaching, which we need to have teaching involved in the CAM-ICU or people aren't going to know how to use it, time constraints, making sure there's time available, seeing this not as a task but as an effective tool that can diagnose delirium, and there needs to be communication with the provider or otherwise using this tool is a waste of time. So I went to a surgical trauma ICU in Philadelphia to get some answers from real life people that use the CAM-ICU daily. So are people using CAM-ICU and is it time efficient? 100% of people, I evaluated 20 different responses, said they used the CAM-ICU. But a little disclaimer is that all nurses for day shift at 9 a.m. and for night shift at 9 p.m. were prompted to use the CAM-ICU. How long does it take to complete the CAM-ICU? So this ranged from 20 seconds to 3 minutes, but overall, if you're only doing one task and it takes 3 minutes of your shift and it can yield these amazing results, then this is great and definitely feasible. Is it effective and what to do if delirium is present? So do you believe that the CAM-ICU is effective in determining ICU delirium? Majority of people with 13 said yes, and there were some people who said no, which I'll get to a little bit later in a couple slides. What is the next step after discovering patient is CAM positive? So almost everyone said notify provider, which is very important because if we don't let the provider know, then the patient might not be able to have the proper interventions in place. Other people said implementing sleep aids, decreasing stimuli, and decreasing visitors, reporting it off to the oncoming RN so that way there's not a lapse in care, and reorienting the patient to the situation, which again is very important. So suggestions for change and overall findings. What would you change about the CAM-ICU? So I thought this was very important for people who did not believe that the CAM-ICU was effective. So 5 people said nothing. So those people thought that the CAM-ICU was perfect. Adding more options for non-sedated patients. So And then along with change, save a heart. So here I did kind of agree. I think the save a heart option is kind of difficult to do for some of our patients may have spinal cord injuries. They may have issues with dexterity, and squeezing your hand for the letter A is just something some patients can't do. So it'd be nice to have another option for patients that just physically can't perform that. And then other people couldn't exactly pinpoint what they thought needed to be changed, but they thought adding more descriptors would be effective in changing the CAM-ICU. So overall, with prompting, all are using the CAM-ICU in just under a few minutes. The provider is notified almost 100% of the time, and effective options are then being implemented. Although many find it effective, many would also change the tool slightly, and the conclusion is that this is feasible, it's done very quickly, it's reliable, and it's valid. So, of course, there's ethical, economic, and legal issues for almost everything, but for here, the CAM-ICU, the management of delirium, whether it's using physical or chemical restraints. So, using restraints can definitely cause ethical issues. We don't want to use these things for our patients, but sometimes it's what's best for them because we don't want them to hurt themselves or hurt other staff members. There's mortality and morbidity involved in delirium, which of course is an ethical dilemma. And then confidence in using the tool. So some people may not feel comfortable using this tool, and then they're not relaying information to the provider, which is then affecting care for patients. So if you don't feel comfortable using this, you really need to speak up and get the education because you could be affected in patients' mortality and morbidity. So economic. Delirium is associated with increased hospital and ICU days, patients sent to rehab and home care facilities. So this is costing a lot of money that is unnecessary. There's a need to educate providers on the use. We need to have training, classes, and this may include time off the floor. So to receive proper education on how to use the CAM-ICU is going to cost healthcare facilities money. And then delirium could cause burnout among providers, leading to staff leaving. I'm not sure if you have ever cared for patients that have ICU delirium in the nursing bedside setting, but it can be very draining. And if your facility doesn't have proper interventions in place to help decrease delirium and your patients you have a high delirium rate, this can definitely cause a lot of stress and cause people to leave, which obviously is an economic burden. And then lastly, legal utilization among providers and having accountability. So providers need to be accountable for using the CAM-ICU and obviously having interventions after that, because if nobody's doing anything about the ICU delirium, then this could cause legal repercussions for facilities and providers. And the next two are delirium and its negative effects preventable before becoming CAM positive, and are care providers doing enough? So this could also be another legal issue. They may see delirium as a completely preventable disease, and if patients are becoming CAM positive, why weren't proper interventions put in place? And is there anything more that the care provider could have done here? Here are the references. If there are any questions, please feel free to shoot me an email, and thank you very much for listening.